Hi everyone, this is Jessica Collinsworth presenting Group A's report on microscopic colitis. Microscopic colitis is the umbrella term for two types of colon inflammation, both of which result in similar symptoms including diarrhea. Microscopic colitis gets its name from the fact that a microscope is needed to diagnose it, as the colon tissue may appear normal upon colonoscopy. The mechanism for diarrhea is thought to occur due to the reduction and absorption of chloride and sodium ions. This is potentiated by cell lesions located in the epithelium, which contributes to a diffusion barrier, resulting in diarrhea. The two subtypes of microscopic colitis are collagenous colitis and lymphocytic colitis. Collagenous microscopic colitis is characterized by a collagen band under the epithelial layer of the colon upon microscopic tissue examination. Lymphocytic microscopic colitis is characterized by lymphocytes infiltrating the epithelial layer of the colon. Although there are visual differences between collagenous colitis and lymphocytic colitis, some believe that the two are merely different stages of the same disease. Lymphocytic colitis is more common than collagenous. Microscopic colitis is normally diagnosed around the age of 65, although about a quarter of patients are diagnosed before 45. This disease is rare in children and is seen more commonly in women. The exact cause of microscopic colitis is still unknown, although it is believed to be related to NSAID and use of certain medications. Smoking, as smoking affects the blood supply to the colon through vasoconstriction. It may also be related to genetics, abnormal collagen metabolism, or an alteration in the function of the intestinal epithelial barrier. This is a list of medications that are believed to be related to microscopic colitis. It should be noted that this high likelihood list includes common medications such as aspirin, NSAIDs, clozapine, PPIs, ranitidine, and sertraline. Before diagnostics are completed, one of the first common differentials could simply be ulcerative colitis, as opposed to microscopic colitis, because chronic diarrhea, abdominal pain, and weight loss are also foundational symptoms of this disease. However, under microscopic analysis, it will reveal that the histopathological changes present in microscopic colitis. Macroscopic visualization of ulcerative colitis differs in that the colon and mucosal lining become inflamed to the point of ulceration, leading to bloody stools. A second differential diagnosis could be gastroenteritis, which can mimic the symptoms of microscopic colitis. However, this disorder's pathophysiological process involves a response to an infection, which then causes mucosal inflammation throughout the intestinal tract. Fever and close contact with others that are ill with similar symptoms may help rule out this cause. A third differential diagnosis could be Crohn's disease, which is another form of irritable bowel syndrome similar to ulcerative colitis. The pathophysiology is also similar in that inflammation occurs in the GI tract. Genetics also plays a factor, but it's thought that an imbalance between tolerance and microbiota of antigens derived from food and immune responses to pathogens is what predisposes an individual to Crohn's and the resulting immune responses. Microscopic tissue examination would help rule this out as a cause. Microscopic colitis was first described in January 1976 in Canada and Sweden, where watery diarrhea syndrome was described in females. In these cases, distinctive histopathological changes consisting of an inflammatory process in the colonic mucosa with characteristic subepithelial hyaline deposits in the lamina propria region were reported. In a large study done in Scandinavian countries, it was found that middle-aged to elderly females were primarily affected, although children with collagenous colitis were also reported. Here is a simulated patient scenario exhibiting the common symptoms of microscopic colitis.
Oh, thanks for seeing me, doctor. My stomach's been hurting so bad these past few days and it's just getting worse. I've been having lots of watery, diarrhea. Sometimes I'm incontinent. my joints hurt. I've been losing weight, but just mainly just the stomach pain and just having lots of watery diarrhea. Can you tell me what's wrong with me?
The goal of treatment is aimed toward improving the patient's quality of life by managing symptoms and inducing remission of the disease process. This is done by educating the patient on avoidance of certain known triggers, including smoking and high risk drugs such as H2 blockers, PPIs, SSRIs, carbamazepine, simvastatin, and ticlopidine. Diet modifications such as avoiding foods and drinks that contain caffeine or artificial sugars, drinking plenty of liquids to prevent dehydration during episodes of diarrhea, and to eat a dairy free and gluten free diet. Antidiarrheal medications will improve symptoms, and oral budesonide, a corticosteroid, is the first line therapy proven to achieve remission. Appropriate surgical referrals for patients that fail medical treatments may be necessary. Complications may arise from chronic diarrhea, including dehydration, malnutrition, electrolyte imbalances, and weight loss. The majority of complications of microscopic colitis are related to the medications to control the disease. Colonic ulceration may occur, possibly related to the use of medications such as nonsteroidal anti-inflammatory. Spontaneous peritonitis with colonic perforation may occur as a result of chronic inflammation. And that concludes our presentation on microscopic colitis. The next few slides are our references. Thank you.